let's move on, because I would like to invite my fellow moderator, Vivian Etsiap-Boama, to introduce the next section of the program. Vivian, can you join us with your microphone on?
Okay. Hello, everyone. Good morning, and welcome to today's session. Moving on, we would like to invite Dr. Dorothea Obui to introduce our speakers for the next session. Dorothea?
Hello, can you hear me?
Yes.
Okay. Good morning, everyone. It's very interesting to see the diverse individuals that we have around here. And it's a very great privilege to have a scientific meeting once again. And this time it's virtual, very interesting. So our theme for this year's scientific meeting is pre-eclampsia, vigilance and screening, diagnosis and management. And we're going to have very interesting sections with various speakers. And I'm very privileged to introduce them to you. So all together, and we'll know what they have to tell us, various experts. And the very first on my list, I have Professor Kitty Bloemenkamp. She's a maternal fetal medicine specialist and a chair for the Birth Center, Wilhelmina Children's University Medical Center, Utrecht, all the way from Netherlands. She has a vast research experience in global health epidemiology. And today she's going to share that experience with us. So she's going to give us an update of the global perspective of preeclampsia. The next will be Dr. Emmanuel Srofenyoh. He is a consultant obstetrician gynecologist and a fellow of the West African College of Surgeons. He is presently the medical director of the Greater Accra Regional Hospital here in Ghana. And he's going to give us an update of the preeclampsia situation in Ghana. Next, we have Enoch Odami Antor, a PhD candidate from the Medical and Health Sciences, Edith Cowan University, all the way from Australia. And he will share with us what he's been doing. He's going to give us something on algorithms, and it's not just algorithms of preeclampsia, a novel algorithm. So let's stay tuned. And we have Dr. Salifu Mohammed Ishaku. He is a director of Population Council's Reproductive Health Program in Nigeria. He provides specialist advice for reproductive health policies to the Nigerian government. And he's going to tell us something about how to prevent preeclampsia in terms of the morbidity and then the mortality. We also have Salim Wangabi. He's a clinical psychologist and at the Greater Accra Regional Hospital. He works with the Severe Preeclampsia Outcome Trial Study, popularly known as a SPORT study. And he's going to give us some mental health perspective on how women with preeclampsia the mental health of preeclampsia the mental health of women with preeclampsia. So these are the breakdown of the presentations that we are going to have today and the presenters as well. And I think this is just an A to Z of what preeclampsia really is. And at the end of all these presentations, I'm sure that we are going to be very up to date of where we are with preeclampsia and then where we are going. So I urge you all to get all your questions ready as we listen to our various presenters. And then Vivian and Joyce will carry on from there. Thank you very much.
Thank you for this introduction of speakers. I would like to give the floor to Professor Kitty Bloemenkamp. I'm sharing my screen right now. Kitty, if you would like me to go to the next slide, just say next slide and I will press enter.
Yeah, thank you very much, Joyce, and thank you very much the organizing committee. It's really a privilege to join this meeting, and we are all in a difficult time, but I think there are also some advantages, and as Joyce already said, there's so many people now in this meeting, and I see some old friends. The only drawback from all this is that I can't join you really live, and hopefully that will be the case next year. I would love to tell something about the epidemiology of preeclampsia. Next slide, please. And that's from the perspective of the INOS, which is the International Obstetric Surveillance System, which is a network organization. And I will tell about that a little bit later. We just heard a very impressive story of a survival of preeclampsia, but we have to realize that still every day more than 800 women are dying because of childbirth, pregnancy, and postpartum. Next one, please. It's not only the mothers, and as we heard from the patient story as well, it are the neonates. They are born too early, too small, and there are many stillbirths. Next one. The good news is that the maternal mortality rate is coming down. And you see it's in some areas in the world globally, it's going faster than others. And for instance, in the high income countries, it's sometimes so low that you wonder if it's possible to bring it down even further. But as you could see as well in the beginning of the global chart, there's a huge difference in it. Next one. This is Ghana, where you can see it comes down. I wonder if Ghana has the very recent figures, but otherwise I could do a suggestion. That's an easy way to collect them is through one of the obstetric surveillance systems, which will be part of my talk. Next one, Joyce. What we know as well is that even if it's low, the maternal mortality rate, it can go up, as was shown recently in the USA, in the States. Next one. Where you can see it's really coming up, and there are many different causes of this. It's not completely clear. You think, is it the case mix? Are the women, are they more at risk to die from childbirth, or is it the access to care, or is it in the providers? Next one. What are the causes of maternal death? Next one. There are many different causes, and I mentioned already some. Are there people around who can help out with the birth or with the pregnancy, the monitoring of the pregnancy and postpartum? Is there access to care? What is the health state of the population itself? But a lot has to do also with the empowerment, I would say, of women. And then a big issue is the fertility and family planning. And then we have the underlying diseases, and I will go a little bit more into this detail in relation to preeclampsia. Next. When you look at the whole picture of where women are dying from, 28% globally is dying because of pre-existent medical conditions exaggerated by pregnancy. And that could be diabetes, malaria, HIV, obesity. And you can see that 14% is caused by pregnancy-induced high blood pressure. Next. When you look globally, you see differences. Still, number one, the cause of maternal death is postpartum hemorrhage. And that's a quality of care, access to care, but also availability of blood products. But as you can see, it's also a difference in the prevalence of preeclampsia and hypertensive disorders, which is in Africa around 10% of the causes of maternal death. And it's much higher in Latin America and the Caribbean, where it's up till 26. Next. When you go to the high income countries, you see from the causes of maternal deaths, it's in the top 3 is hypertensive diseases and preeclampsia. So worldwide, I would conclude it's a huge problem, preeclampsia. But maternal mortality is only the tip of the iceberg. We have severe morbidity, and one of them is eclampsia or liver rupture or cerebral bleedings. Then you have the morbidity itself, and then you have the uncomplicated pregnancies. Next. The International Network of Obstetric Survey Systems is a network, voluntary, I have to say, in which countries are working together and they are trying to collect in the same way population-based data on different subjects on maternal mortality and morbidity. Next. Here you can see different countries. It's like the UCOS, they started actually. So in the UK, it's in Italy, it's in the States. They are in some states, members are starting with it on the population-based collection. Germany, they just started. It's Belgium, Australia, France, Suriname. Now we have new members, which are South Africa and hopefully Ghana soon. Next one. Here you see again around the world, globally. Next. How is it done? It's done in different ways in countries, but from the Netherlands, the Netherlands Obstetric Surveillance System, we did ask all the hospitals with maternity units to have one person who does collect all the data. And we send out very simple, just one email every month to ask them if they have cases of either maternal mortality, and for instance, eclampsia, severe postpartum hemorrhage, or like now, COVID positive women. And in that way, we get back the case, and then we can ask for the whole case file. And then next one. We do in all those countries from the INOS, we use the same definitions and methodology. And then a good thing about it, I think, is that you can see if there are differences between countries, but you can also compare management strategies. And I think that are the lessons to be learned from this whole network. The other robust thing is that we use population data. As I said, you can, the lessons learned, and you can make recommendations for that, and then you can implement this in a plan, do, act cycle. Next. In the Netherlands, we learned in, say, around 2006, and we did the Lemon study, which was a prospective nationwide collection of all eclampsia data, that we had a much higher incidence than other countries, which were all high-income countries. And then we were thinking, what's happening? Is this because we use different definitions of eclampsia? Are there different patient characteristics? Or is the management different? In all the cases, we could see that about in 85% of all the cases, there was substandard care. Then we compared, next, within the INOS setting, we compared our data with the UCOS, with the UK data. And we found out they did use another definition. But at the end, when we combined it in the same way, using the same definition of eclampsia, next one, we could see that there was a little bit difference in case mix. So in the Netherlands, we had more women who have multiple pregnancies, so twin pregnancies, and they had a higher maternal age. But there was also a difference in management. In the Netherlands, less antihypertensive drugs were used when the women came in with eclampsia, and also there was less magnesium sulfate used. And the other thing is, after an eclampsia, in the Netherlands, we would wait longer before women to deliver. So from this way, we learned we have to change something. And we implemented all those lessons into our guidelines. And then we used the NETOS network again to do a new registration, now in 2013 till 2016. And then we could show that 60%, there was a 60% decrease of eclampsia incidence. So I think that's also a good thing of all those registration systems, that you can also show that you are really doing the good job and that you are showing that your incidence is coming down. The other ones are the ones from amniotic fluid embolism and cardiac arrest. And then you can go into detail. What are the characteristics? What's the management? What can we learn from this? Next. From the very recent data in the Netherlands, we could learn also that at the moment we do use actually a high rate, we do have a high rate of magnesium sulfate for prevention of eclampsia. But we also, what we do see is that the monitoring after women is coming in with the eclampsia, the monitoring is there, but the action taken to decrease the blood pressure is not fast enough. And I think that's one of the lessons to bring it even further more down, that you really need a system where you act really more quickly on when you find a high blood pressure and you start antihypertensive medication. The INES itself, as I said, had problems because when you want to compare data globally between countries or regions, you need to have the same definitions. That's why we did perform as an INOS Delphi, where we had at the end, after several rounds, we had an accepted definition by the whole group. And that's how we now, when we start a collection again of eclampsia, we would use this definition. I think those obstetric surveillance systems are also very helpful in rare diseases, or if something is emerging, like we have now the corona crisis pandemic, where we could do now in 70 countries in 1 month, we did start up in 17 countries within the INOS network. We did start collecting all data on women who are COVID positive. And the good thing is that I can show you already, next, Joyce, already now for the Netherlands on the left side, the numbers, how many women are infected with COVID positive, who are COVID positive. You can see it on the left one, and you see it's more in the west of the Netherlands than in the middle. But also from the UCOS data, you can already see that what are risk factors for women to have COVID positive, who are more vulnerable. And that it's, again, maternal age, it's obesity, and it's Black women, and it are the ones with underlying diseases such as hypertension. These data are just now. And I think in this way, and that's how I want to conclude, these surveillance systems, which are really, I have to say, rather easy to install, and it depends a little bit on your regulations about privacy. We do it by a mailing system, but you have also countries where they even do it by WhatsApp. Like in Suriname, they had a system where they even could send, say, we have a case of eclampsia. I'm not saying that WhatsApp is safe regarding the privacy, but when the regulation is not that strict, that could be an option as well. But I think in that way, you can register the maternal deaths, the near-miss maternal morbidity cases, but also the perinatal mortality and morbidity. And in that way, in several countries, there's an audit installed where you can go next to the comparison within the country with other countries, go into more detail in audit, but you need a no blame, no shame culture for that. And you have to do that with more people. You can do the data analysis. You can say, these are the good practices. Here can we learn something from it. from the lessons learned, you can go up till the guidelines and implement it in the new guidelines or make guidelines when they are not there. You can have research adhere to it, and then you can go further around the cycle. And I think this is how you can improve maternal and neonatal health. So in summary, next, I think eclampsia cases may be accurately defined using clearly defined clinical criteria. And I think Ines did make an attempt to make a good definition for that. When you use the uniform case definition, you can easily compare between countries and between regions. Preeclampsia management does differ across the world. And I think the network can help to collect additional clinical information also on rare diseases or pandemics, and can inform to make a better future management. Next. In conclusion, it's a pity that I can't go now to Ghana, but I'm sure we will meet again like we met last November in 2019. And here you see many of my colleagues and friends in Ghana. And again, thank you so much for the invitation. And this is a picture of the whole Netos and Ines team.
Thank you, Kitty. We will, there will be an opportunity to ask questions after the next speaker, and I would like to invite Dr. Srofenyoh to the floor. Dr. Srofenyoh, can you share your screen? In the bottom, you see the green icon in the middle with share screen, and if you then select your PowerPoint, you should be taking over, and we should be able to watch your screen. Yes, we can see it. If you press full screen, then we can. Yeah, thank you. The floor is yours. Sorry, Manuel, you're still on mute. Let me see if I can unmute you. Okay. Yes, now your audio is on again.
Yes, so thank you very much, Joyce, and all the other organizers behind the scene who have made this community, this gathering, virtual gathering possible. And the topic of my discussion this morning is pre-eclampsia, the Ghanaian situation. I'll be brief, and then I'll leave space for questions. This is going to be the outline of my presentation. I'll talk a little bit about the prevalence in Ghana, the changing impact of pre-eclampsia in Ghana, perinatal outcomes and case, and I'll do one case presentation before I conclude. So by way of introduction, as had been said earlier on, pre-eclampsia and other hypertensive disorders of pregnancy have become a major cause of maternal mortality in Ghana, especially in the major institutions of care, be it Accra and the other cities across the country. It has become a major cause of maternal mortality. And indeed, it is one of the reasons why Ghana failed to achieve her SDG targets, SDG 4 and 5 targets. Hypertensive disorders are also important cause of maternal morbidities, and the chart has been shown earlier on. Sometimes we have patients who end up with acute renal failure and progress to chronic renal failure, cardiomyopathies, and other complications. It also accounts for significant measure of perinatal morbidity and mortality. If you go to our NICU, neonatal intensive care unit, you have so many babies delivered prematurely who are there, and the majority of them succumb as a result of this condition. It also contributes significantly to hospital admission. There are times that when you go to our wards, the entire ward is full with women who have pre-eclampsia, who are admitted to the ward awaiting pregnancy prolongation a little bit before they are eventually delivered. So this is how serious the condition we have on hand is. Now you see the graph. This is the graph that shows how Ghana has fared over the years as far as maternal mortality is concerned. You see that initially, in the initial years, we've made significant progress, but from 2010 onwards, progress has become we've not been making much progress. You see that our graph has virtually flattened. And several analyses have shown the lack of progress in survival from preeclampsia is one of the reasons why we are not making much progress. Because we've made significant progress when it comes to hemorrhage and its management, when it comes to unsafe abortions and their management, and so on and so forth. But when it comes to preeclampsia, progress has not been as much as we would all like to have it. So I'll talk a little bit about prevalence in Ghana. It is so difficult to get the accurate prevalence in Ghana. The true burden of hypertensive disorders in pregnancy has been difficult to determine. Worldwide, we know it's estimated to be around 10%. But in Ghana, there have been a few studies, which I'll make reference to. Is usually put between 6.55 to 7%, Ahenkura et al., 2009, and Professor Obed et al., 2006. However, in 2015, Joyce Brown, who is incidentally is also a member of this panel, carried out a cohort study where the prevalence of preeclampsia in Ghana was put to 7.5%. The prevalence in major referral institutions like Kolebu Teaching Hospital, the Greater Accra Regional Hospital, RAGE, and the other bigger hospitals where the cases are referred to are obviously higher. And one study at Kolebu Teaching Hospital put the prevalence at that hospital to 21.4%, which is very high. This is a chart that shows the prevalence rate in the Greater Accra Regional Hospital, the hospital where I work. And you can see that over the years, the prevalence has been relatively high. It's ranged between 15.5%, and then most recent year, 2019, the prevalence has jumped to 22.2%. And this is very high. It is partially because of our referral nature, but it also reflects the numbers that are coming, the numbers that are being discovered every now and then at the various district hospitals before they are referred to us. I also have a chart there showing case fatality. And as you can see, case fatality for preeclampsia in our mothers, in the women who develop preeclampsia, the range is between 1.2%. Sometimes we do well and it's around 0.5. Averagely, I'll put it at around 1% case fatality rate. And the implication of this information is that when you have, for every 100 women who have preeclampsia, it means that in Ghana, for every 100 women who have preeclampsia, probably one of them will lose their life. Or when you have within our institution, for every 100 women who comes with preeclampsia, one loses her life. That is the practicality of the information that I have projected. There is also another thing that we have discovered recently, that there is a changing pattern of preeclampsia death in Ghana. There has been a changing pattern. So please pay particular attention to this chart. In 1963, one of our senior consultant professor, in his data collection, showed that hemorrhage contributed 65% of maternal mortality in those times, and preeclampsia contributed only 15.4% in 1963 to 1967 data, as you can see. But the story has changed over the years. Between the 1980s to 1994, that 10-year period, preeclampsia and hemorrhage were virtually neck to neck. But from the 2000s, you can see preeclampsia or hypertensive disorders overtaking hemorrhage as a leading cause in the facility in which this data was collected, and that was Kolebu Teaching Hospital. And then in the 2010 and further advances took place, and then you see more and more cases of women dying from preeclampsia rather than from hemorrhage. So this is the situation that we have in most of the major institutions. So Kolebu Teaching Hospital, the Greater Accra Regional Hospital, and then Komfo-Anokye Teaching Hospital, all the bigger institutions that receive more of the cases. This is the story that we are seeing now. It is no longer hemorrhage as a leading cause, but it is preeclampsia in these facilities. This is data that we also collected in the year 2016. And as you can see from this data, we collated preeclampsia death across the entire city. We are no longer talking about what is happening in the bigger institutions alone, but what is happening in all the institutions in the city. And we realize that as far as the entire region, let's say Greater Accra region is concerned, hemorrhage contributed 63 women died from hemorrhage, and as many as 60 women died from preeclampsia. And so this shows clearly that even at the regional level, when we look at the entire region, and for many other regions, preeclampsia and hemorrhage are becoming neck to neck. So apart from the fact that in the bigger institutions, preeclampsia is becoming the leading cause of death, even when we take all the institutions together, preeclampsia is still a significant contributor to maternal mortality in Ghana. Again, this is data that we collected over a 5-year period from 2015 to 2019. And again, over this 5-year period, as you can see, obstetric hemorrhage contributed 48 cases, 33.3%, hypertensive disorders or preeclampsia. This is 7 women over this 5-year period passed away, losing their life, and that contributed 46.5%. And you can see the rest as it unfolds. So this is the situation. Hypertensive disorders, preeclampsia is now a leading cause of maternal mortality, even in the Greater Accra Regional Hospital. And so we did further analysis in Ghana here to appreciate what the underlying factors that are responsible for mortality. After postmortem is done and after audit, we come to some conclusions. And this is how it panned out. Cerebral vascular accident contributed 31.3%. Fluid overload, which is mainly iatrogenic as a result of management. Maybe we administered excess amount of fluid because preeclampsias don't tolerate fluid. That contributed 31.3%. Multi-organ failure like kidney failure and all other organ failure contributed 18.8%. And renal failure alone, when we analyze those patients who have renal failure, contributed 12.4%. So these are the underlying factors why women lose their lives as a result of preeclampsia. So it's going to become necessary in the future to see how we can prevent or minimize these complications in our women. Which management protocols do we use so that we avoid fluid overload in such women? And how can we make sure that we minimize issues of multi-organ failure and acute renal failure? This information, the information on this slide, will serve as an important source of further studies for researchers who are on this platform. Quality of care. Quality of care of preeclampsia women is another important area to look at. Normally, with our current dispensation, the protocol that we use depends on early detection. So we have programs in place to make sure that women who develop preeclampsia are detected early detection, control of blood pressure, and prevention of fit using magnesium sulfate. Magnesium sulfate is widely used in Ghana. And then lastly, timely delivery. Now, apart from fatality rates, which are projected earlier on, eclampsia index can be used to monitor effectiveness and the quality of care to these women. To the extent that if we are getting more and more eclampsias, then we know that yes, we are not managing them well enough. We don't have to wait for death. We don't only have to use mortality as an index. We at the Greater Accra Regional Hospital here have decided to use eclampsia index to determine how well patients are being managed. So this actually reflects women who are managed from the sub-district level to the district level before they get to the referral institutions. So because that is where they are detected from, that is where the initial management are started, and that is where they are supposed to even commence magnesium sulfate before they are eventually referred to the higher centers. So the more eclampsias that we get, the more we can assume that care in the periphery and also in the central institutions are not good enough. However, as you can see over the years, from 2015 to date, 2019, we can say that pre-eclampsia rate, the eclampsia rate or the eclampsia index is reducing a bit. It was as high as 7.9 to 8% initially in the earlier years, but last year the eclampsia index in Accra Regional Hospital was 5.8%, and that was 2018. In 2019, it has improved a little to 5.6%. But again, a whopping 5.6% of the women developing eclampsia is high, and we are hoping to have a situation in the near future where virtually none of them will develop eclampsia, that will be able to manage them early enough so that they don't even develop eclampsia. The reason why we chose eclampsia as an index is that we know that once the woman develops eclampsia, the woes of the woman will become higher. The risk of death is higher. The risk of having multi-organ failure is higher. The risk of all the other complications, intracerebral bleed, is higher, and so on and so forth. So if we can identify this as a complication that we can reduce, then we will be on the right path to reduce the other complications. So talking about perinatal outcomes, again, there have been relatively few studies in Ghana which really focus on perinatal outcomes. I will talk about a few of them. There was a study conducted in the Ridge Hospital, published in 2015 by Joyce Brown et al. And that study showed that women with chronic hypertension have a higher risk of preterm delivery, with an average relative risk of 4.3%, 95% confidence interval being 1.3 to 4 to 38. And then women with preeclampsia, women in that study, it was found out that women with preeclampsia have even a higher risk for low birth weight, with an average relative risk of 7.95%, and then a higher risk of neonatal death, with an average relative risk of 18.1%. So this is the situation. Even if the woman traverses to term, there is still a risk to the baby. This is another study that was conducted in Kolebu Teaching Hospital, looking at the outcomes of hypertensive women with hypertensive disorders who have progressed to gestation of 37.4 weeks. And this was published in 2017 by Bonsafo and his team. I'm sure Bonsafo is on this, is in this meeting. And in that study, they found out that 24.7% were admitted who had problems, significant problems, for which they needed to be admitted to neonatal intensive care unit. 15.2% had neonatal respiratory distress syndrome, even though the pregnancy has advanced to as high as 37.4 weeks. 3.8% required ventilatory support. Stillbirth rate was 6.8%. Early neonatal death rate was 3.8%. Severe intrauterine growth restriction, 6.1%. Low birth weight was 24.7%. But above all, when we summarize everything, perinatal mortality rate was 10.8%, which means that for every 100 women who are delivered, 10 of them, 10.6%, 10 of them will lose their baby. That is, even when the pregnancy is carried to term to 37 completed weeks, still 10 of them, for every 100 women delivered, 10 of them loses their baby. And so this again, we should portray to you what would rather be the situation even when the pregnancy did not move to term. It will even be worse in our circumstances. Before I bring my presentation to a close, I would like to make this short case presentation to illustrate the socio-economic and emotional impact of pre-eclampsia places on our women and their families, and also to illustrate the fact that we still don't fully understand this disease condition. I'm talking about Madam AA, who is currently 35 years old and has been married for 10 years. She has had about 11 pregnancies in the past, and I've lost all of them through pre-eclampsia between gestational ages of 24 weeks and 28 weeks. So hers, we can describe as an early onset type. Of the 11 pre-eclampsia episodes, this woman had eclampsia 6 times. And indeed, when I saw her antenatal book and I saw the number of eclampsias this woman has had over the years, I was so much alarmed. Now, in the last eclampsia that she had, she ended up in an intensive care unit where she has to battle for her life. After a long battle, she survived. The index pregnancy for which she was referred to the Greater Accra Regional Hospital, she was referred to us at 12-week pregnancy. She was already 12 weeks when she was referred to us. And by the time she came to us, she already hypertensive. She had developed chronic hypertension. Her BP then was 180 over 120 already at the gestational age of 12. We managed to control the blood pressure to allow the pregnancy to progress. She was on all the medications that we can think about, all the possible medications, antihypertensives. She was on soluble aspirin. She was on calcium. She was on folic acid. She was on multivitamins that contain vitamin B12. Everything that we can think about, this woman was taking the medication. However, by 24 weeks, she experienced an intrauterine fetal death and lost the baby. After induction and delivery, and after she's been discharged, this woman called me and asked me a question, "Doctor, so what should I do again? What should I do again? I've done everything. I've been referred here. You've given me all the drugs that you can give me, but what should I do again?" And I can tell you, I'm still reading and looking for the answers. I couldn't answer her. I'm still reading and looking for the answers. So the question what I want to say now is that what are we doing as a country? Because I'm to talk about pre-eclampsia, the situation in Ghana. There are a number of interventions that we are putting in place in Ghana. The first one is pregnancy school. And in Ghana here, we are implementing pregnancy school, both institutionally and then also within the communities. So therefore, it is not only in the hospitals that we organize pregnancy schools. Sometimes of the day, within the hospitals, when they come for antenatal care, there are midwives who have been trained who give lectures on various important topics, how to detect, how to monitor yourself for development of these complications and so on and so forth. But we have also decided to take pregnancy school right into the communities so that husbands, grandmothers, and other members of the family will also understand and support the women within their communities who may be pregnant. We've also designed pre-referral management protocols because we want to be sure that once the woman presents to the nearby district hospital or the sub-district hospital, the right things are done before they are even referred, because time is of the essence in those circumstances. So we have designed pre-referral management protocols. So they have to know which blood pressure, at which blood pressures should they give magnesium sulfate, which antihypertensive to use by the midwives, and what they should do before the patient is referred. So that is currently under implementation. Social actions are also important. So actions like APECGH Ghana, what APECGH Ghana is doing is in the right direction and is really supporting the Ministry of Health and also the Ghana Health Service and the obstetricians to help bring education and information to the public improved clinical management protocols is another intervention that we are putting in place, making sure that even within the bigger hospitals, we have the right protocols in place to manage the women so that we can improve the outcomes. And that is also in place. Above all this, one important thing that we have also engaged in is research into pre-eclampsia. There are currently a number of research that are going on at the Greater Accra Regional Hospital together with other clusters of hospitals. We have the sport validation study going on. We have the sport bio study going on. And then several other sport-related studies that are being conceived that are currently going on, just to understand how best to manage, especially women who present with early onset type of preeclampsia, how best we can manage them to delay the pregnancy a little, or which are the ones that we should just deliver immediately. Also to understand whether there are any genetic factors that are responsible for preeclampsia, and so on and so forth. So by way of conclusion, I want to state that the burden of preeclampsia in Ghana is huge. It has become a leading cause of death, or leading cause of maternal mortality in most big hospitals. Nationally, its contribution to maternal mortality and morbidity is increasing. It also contributes significantly to perinatal mortality and morbidity. It imposes, and this is what sometimes we don't pay attention to, it imposes a huge social and economic cost on the family. And above all, we still don't understand the full ramification of this condition in Ghana. There is therefore the need for all of us to focus research to understand the underlying mechanisms, to allow prevention and effective treatment, and also management of the condition. This is an urgent call in order to prevent needless death and to bring smiles back on the faces of thousands of women and their families who are suffering from the impact of this condition. Thank you so much for listening to me.
Thank you, Dr. Srofenyoh, and thank you, Prof. Bloemenkamp too. I am ending the shared screen option because we've reached our Q&A part. There are in the chat a number of questions have been asked already. I would like to give Isaac Ampoma first the floor to ask his question. Isaac, you should be able to unmute yourself and ask your question.
All right, thank you very much. That's a very wonderful presentation. Thank you, Doctor. Doctor, I work for Ghana Coalition of NGOs in Health, and also I'm in Ghana working for Concerned Health Education Project. You know, Coalition is the umbrella body of all civil societies in Ghana. Doctor, is it possible that we can get multiple infections, pre-eclampsia and also hemorrhage? Again, also in the area of the pregnancy school, in the communities, how do we sustain that? Some of our findings have realized that the pregnancy schools are not being sustainable. And of course, all these cases will end up at the hospital sessions. And then finally, also, with high blood pressure in pregnancy, is it as a result of lifestyle or it is as a result of poverty? Thank you so much.
There are a few questions. Dr. Srofenyoh, do you want to start? And Prof. Bloemenkamp, do you want to add?
Yes, so please let's have the questions in crops. Can you hear me?
Yes, we can.
Yeah, so we have the questions in crops. So if there are other few questions, we can add it before.
Because of time, please answer this one, and then we can see how much time we have to also come to the other one. So please answer this one first.
Yes, so thank you so much. I hope I can be heard. Yes, thank you so much for the questions. First of all, interestingly, these two leading causes of death, there is an important linkage between preeclampsia and hemorrhage. And that is complicated preeclampsia sometimes develop when the woman has severe preeclampsia. There is a complication which can lead to excessive bleeding. We call that disseminated intravascular coagulopathy, or DIC for short. That is a complication which is also very common. And when the woman has that complication, there is a very high risk of bleeding excessively to death. And indeed, some of the deaths that we have had in pre-eclampsia are because they develop these bleeding complications and therefore lost their life. The other question, so therefore there is an important linkage between these two leading causes of death. The other question has to do with, are pregnancy schools sustainable? We wish we could sustain this because it is an important opportunity for us to deliver life-saving knowledge to the population, both the pregnant women and even the community members. So we wish that we can come together with all the other NGOs and work together and make sure that these pregnancy schools are sustainable, because that is the only way. Because some of our mothers will not be able to go online as we have in the developed countries, where a woman can go online and read everything about the problem that he may be suffering from. That may not be the case in Ghana. And so it is important that we present this as a way of giving information, the much needed information to women within the communities. The reason why the community pregnancy schools is particularly important is that both women who are not yet pregnant or women who are pregnant and their family members, their husband, will benefit from the information that are delivered there. So let's take it up. Thank you so much.
Thank you. I would like to invite Rosalind Kudo to ask a question. Rosalind, you should have been unmuted now. Yeah.
Hi, good morning.
Good morning.
Please, my question to doctor is, for this situation to go down, what training is there for the health workers to equip them to manage cases on pre-eclampsia? On pre-eclampsia, the training. What training is being provided for the health workers? That is all what I want to find out from them, from doctor. Thank you.
Thank you. Thank you very much. I hope you are hearing me. Hello? Okay. So what training is available for the health workers? So the first thing, as I said earlier on, is that we are developing advanced and improved management protocols. First of all, the pre-referral protocols. So when we develop this document, we make sure that we are training the midwives who are working within the district and the sub-district areas, so that they'll be very conversant with these pre-referral management protocols. So what should I do when I have a case before I even refer the patient? What basic treatment should I give to this woman before the woman is referred? So that is going on. That is something that is ongoing at the sub-district and also at the district level, where the patient may first report to. However, at the receiving end, the facilities that receive these cases must also have a good protocol. Again, we have developed protocols for management of pre-eclampsia, and then training has gone on for the doctors within these institutions to manage the condition properly. They have been trained, doctors and nurses. There are standard protocols that they have been trained on, depending on the severity of the blood pressure, depending on the presence of any organ damage. What should you do? When do you transfer the woman to the intensive care unit? Or when should the woman be transferred to the high dependency unit? All these systems have been put down in protocols, and staff are being continuously trained. But I have to admit that probably the training may not be adequate and may not be very adequate. So one of the things that we'll take out from this meeting is the need to intensify training of our staff. The fact that we still have deaths means that we are not doing all that it takes to do. And so we need to intensify training. We need to sharpen our management protocols to ensure that we are saving more and more lives from this condition. Thank you very much.
Thank you. Beatrice Amoa also has a question, and I would like to ask Kitty Bloemenkamp to answer it. Beatrice, I'm unmuting you now so you can ask your question.
Thank you. Please, my question is, we have been doing the preeclampsia research for quite a long. I joined the preeclampsia research 3 years ago when I joined university. My supervisor is here. That's why I'm sitting in the phone. Hi. Please, my question is, why is it that we have still not found the etiology of preeclampsia? We've done a series of research. I mean, I acknowledge that all, but why is it out now we still haven't found? If we find the cause, I think that we will see the way forward. But we've been doing a series of research, but so all researchers keep saying that the etiology is loosely, we still don't know what is causing. What are we not doing right? That is the question I have for. Thank you.
Okay. Yes, and Kitty, maybe what is good to know is that Isaac also asked a question about lifestyle and poverty, and I think the both focus on etiology, so you can probably answer 2 questions in one answer.
Yeah.
And because we're running a little bit out of time, you asked for slide 2.
Okay, thank you, Joyce. Yeah, maybe you can share one slide I didn't show for, yeah. So about the etiology of preeclampsia, I have to say one who knows how it really does work will get a Nobel Prize. But one of the things is that we know there are several risk factors. And the risk factors to get hypertensive diseases in pregnancy are mainly obesity, underlying diseases such as hypertension, cardiovascular diseases, diabetes, autoimmune diseases. Age is, the older you get, the higher the risk is. And it's also if it's running in a family and if it's your first pregnancy. The other thing is we think there's a genetic contribution as well to preeclampsia, and probably it's the combination of the gene environment interaction why you do develop preeclampsia. So it's a multi how do you say? It's more factors are involved to develop preeclampsia. But even women who have really, who are completely healthy can develop preeclampsia. And that's the difficulty, I think, in preeclampsia, who are the ones who are at risk, but we will have a talk on that later. And I agree, there's a lot to do in management in Ghana. When I hear the figures who are coming out from Ghana, I think it would be really helpful to have really good statistics and to go into detail in these statistics, in these data, do audit to see what's not going well, and then you can do the things like team training and so on. Is this an answer, Joyce?
Thank you. Because of time, we only have, unfortunately, time for one more question. And I would like to invite someone we've seen already in the video that Koiwa shared, Mr. Dennis Ofusu-Apia. And I would like to invite him to ask this question. You should be able to, I need to unmute you. Yes, you should be able to speak now. Just a minute. Yes.
Can you hear me, Joyce?
Yes, we can. Welcome.
Okay.
And we're very pleased that you're here. Because
Thank you so much.
As the husband of Prof.
And we are grateful for what you're doing. It's a great work. Yes. I actually want to be listening. But I think what we are driving at basically is how do we get solution to the things that we are engaged with. My thinking, because of the disease is so scary, right? Because of the nature of it. And so I am thinking of a lot of solutions, and I'm interested in that. The first thing I'm thinking of is that if we have a program in line that appears to sort of enable us to assess the history of a woman in terms of from grandparents to parent to herself, like in our situation, then what I would say is that maybe that person should not have children in a natural way at all. You should be advised to decide whether you are going by surrogate and avoid going through that process. Because in our situation, we have had 4 and we only have 1 child. The question is, how many times would you want to go through before you survive with 1 or 2? And we know the fatalities are high. And in Ghana, here, as doctors have said, Greater Accra, that's the leading cause of maternal death. The other one is, the little I've heard, you are the medics, you might appreciate it better than I do. If the whole thing is that the process by which food get to the child, the unborn child, is what is blocked or poisoned, then can we find a way to get, but artificial means, to get food to the child without necessarily passing through what the body is made up of, the natural process? Is there something that we can do by that so that the child can survive? The next one is, if is the case that the child, the body of the mother is so heated so that she's not in a position to contain the child. Have we advanced in the medical world so much that we can immediately take the child and baby the child through artificial process for the child to grow? Because my big brother lives in UK, and he told me a story about a child who was actually delivered, I think, less than 4 months, and that child survived in UK. But it appears that's not the case in our part of the world. It might mean, what do they have there that we don't have here? Can we get it here immediately, and how much does it cost? So that we find a way to get the money put together and buy the system to do that. So I think that if we are able to quickly, immediately be able to assemble these ideas, then we will be in position to save so many of our women and their unborn children. And I think that's my contribution that I will talk. Thank you so much.
Emmanuel, would you like to comment first and Kitty add after? There are 3 issues raised, so please be mindful.
Yes, Joyce, these suggestions, the first one has to do with what about the concepts of surrogacy. When we place this in the context of developing nation, we are not sure whether this can be a good solution, because surrogacy means that you have to go in the direction of IVF and then surrogate the baby to another mother. There are issues around it which may not be very easily culturally acceptable to the women, especially when we look at the communities. And then the other one has to do with what is at the level of the development of our neonatal intensive care services. This is an area where we need to do further investment to make sure that at reasonable gestational ages, when the babies get to neonatal intensive care unit, they survive. As he talk about a story of somebody who survived in the UK, but we have a less developed newborn neonatal intensive care system. So that is why sometimes we are forced to allow the babies to grow a little bit so that there will be some success in terms of the baby survival. Again, it's an area where further work is needed to see what is it that we can do so that the babies will survive better. So it's something that I've taken on board to think about. Thank you.
Yeah, I think in addition to this, I think when you think about why women do get preeclampsia, it does start very early in pregnancy, even at 5-6 weeks. And so we have to do something about prevention beforehand. And I think we can talk about that later. The other thing is the outcome of the babies. Yeah, that's really depending on how far you want to go. And I know in the UK and the Netherlands, we keep babies alive at a very early gestational age. But sometimes you get at a point where you really think, what's ethical, yes or no, or how is the life of the baby afterwards? So that's a large discussion about that. Should you really try to keep a baby alive at what we do now, 26 weeks, 450 grams? How is the life of the baby? So afterwards, I think you need a lot of follow-up to give an answer on this, and that will take many years. And maybe you can learn from that, from the high income countries, how that is going before starting to eat something.
Okay, thank you for your answers. I would like to propose to have a very short break to allow everyone to stretch his or her legs, get some water, coffee or tea, and we'll resume in 5 minutes with the next set of presentations. Unfortunately, we cannot have a round of applause in this digital format, but Bloemenkamp, thank you on behalf of everyone. You're more than welcome to stay for the rest of the session. We would really like to hear your further thoughts as well. And everyone in the chat, you can also indicate a thank you so that they can read your applause, so to say. We'll resume in 5 minutes.